Hi guys, welcome back to the channel. We are discussing the corticosteroid treatment and intensive insulin therapy for septic shock in adult. This study published in JAMA publication in 2010. COIITSS.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of some whatever. Under any circumstances, the author accept no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question: in a patient with septic shock who are treated with a corticosteroid, does the tight glycemic control compared with the less tight glycemic control reducing hospital mortality? Background for this study: the septic shock is characterized by the dysregulated host response to infection, including hypotension, that is not corrected by fluid administration alone. The administration of corticosteroid, hydrocortisone in particular, is a thought that to attenuate this response, and evidence suggests that it reduces the degree of hypotension, although it may not be ultimately preventable. Or consequences of corticosteroid administration: dysregulation of glucose control, which may be harmful. It is possible that the intensive insulin therapy with aim of tight serum glucose control with a normal physiological parameter may counteract some of the harm from the corticosteroid, allowing them to be more beneficial in patients with septic shock. This trial also investigated the effect of additional fluorocortisone on the secondary outcome, and the interaction between the glucocorticoids and mineralocorticoids had not been adequately studied in patients with septic shock. Design for the study: randomized control trial to multi-center trial, 2x2 factorial design generating the 4 group of patients. Arm 1 intensive insulin therapy versus conventional glucose control. Arm 2 fluorocortisone versus non-fluorocortisone. Open label patient clinical staff, research staff were aware of allocation. No attempt to blind participant to or staff. No placebo therapy was used. Centralized web-based randomization process with permutation blocks of variable size to conical allocation prior to recruitment and randomization. Hydrocortisone and other studies therapies were standardized and control keeping with the 2004 Surviving Sepsis campaign guidelines. Intention to data analysis: power calculation based on only one arm, intensive insulin therapy versus conventional glucose control. Estimated 50 in hospital mortality control group, expected absolute reduction 12.5. This can be compared with a critical relative reduction in form B in a Van de Berg intensive insulin trial. This is also an animal trial. We can further lecture will discuss this trial. Statistics based on about alpha 0.5 power 80%. Setting for this ICU. 11 intensive care unit across the France. Duration for the study January 2006 to January 2009. Population for the study. Inclusion criteria. I don't know many of the criteria of ACCP observed for the severe sepsis. SOPA score more than 8. Requirement for vasopressor and drops to intense systolic BP more than 90 mmHg or more than 60 mmHg. Receiving hydrocortisone 50 mg IV every 6 hours. Exclusion criteria for trial: pregnant woman, moribund patient is expected to die immediately. 946 patients screened, 509 were included and all were included in primary outcome analysis. 24 were lost to follow-up after the hospital discharge, lost for some of the secondary outcomes. Groups well balanced for major baseline variable. Intervention: Arm 1 intensive insulin therapy adapted from the Van de Berg trial. Insulin was initiated when blood glucose more than 6 millimole per liter, 110 mmHg per dl. Comments and 2 units per hour. Blood glucose level were checked at least 4 hourly for the first 3 hours, less frequently thereafter if stable. Target range is 4.4 to 6.1 millimole and in 80 to 100 mg per dl. Hypoglycemia was treated with a 10 gram of glucose. Insulin infusion were stopped on discharge from intensive care unless the patient presented with the insulin dependence. Arm 2 addition of fluorocortisone. Hydrocortisone was continued. 9-alpha hydrochlorocortisone 50 microgram was administered via nasogastric tube each morning at 8 a.m. for 7 days. Control one conventional glucose control. Physicians were advised to follow 2004 surviving sepsis campaign guidelines and not to follow intensive insulin therapy trial protocol. Maintenance of blood glucose was less than 150 mg/dl after the initial stabilization. Maintenance treatment dose and route of insulin was made the treating physician discretion. Arm 2, no addition of fluorocortisone. Hydrocortisone was continued. Fluorocortisone was not administered. No placebo was administered either. When using common to both groups, physicians were advised to follow 2004 surveillance sepsis campaign guidelines. For all non-trial therapies, hydrocortisone was administered as a 50 mg intravenously IV every 6 hours to all patients for 7 days from the recruitment. Outcome: good separation between the group was achieved with a statistically significant lower blood glucose observed in the intervention group compared to the control group. Primary outcome: there was no statistically significant difference in the hospital mortality between the intensive care insulin therapy versus conventional glucose control. Intensive insulin therapy in hospital mortality 40.9, conventional glucose control in hospital mortality 42.9. Absolute risk increase is 2.97. Relative risk 1, hazard ratio 1:4. 1.04. Secondary outcome: there is no evidence in interaction with the fluorocortisone. In hospital mortality 42 versus 40.5, absolute risk reduction 2.98. Secondary outcome: not any evidence found. Strength for the trial. Hypothesis is reasonable given to describe the purity and randomized control trial design for arguably the best method to investigate this hypothesis. The multi-center design includes the external neutralization. The centralized wave-based randomization process is the gold standard for the counseling to book allocation, preventing the allocation bias. Our time was based on previous data. Although the retrospective, it was all optimistic to accept the intervention to reduce mortality by 25%. The statistical method and intention process analysis plan were appropriate for the data types. Attempts were made to standardize the non-study care according to the published guidelines. Good separation was demonstrated between the groups regarding the blood glucose, increasing the internal variability and result. The primary outcome is objective primary, reducing the observer bias, simplifying assessment and analysis. Small confidence interval around the null effect point suggests the true benefit of harm unlikely, which then the conclusion of this trial. Weaknesses for this trial: the hypothesis tested tight glucose control with a target of 4.4 to 6.1 millimole per liter against less than glucose control with a target of less than 8.3 millimole, which are arguably not be dissimilar and one in the very more not be arguably tested with this trial. Compare this with the nice sugar relaxed glucose control with 8 to 10 millimole per liter open level design by introducing the significant biases as a clinical staff may unconsciously treat the patient differently depending upon their group. Allocation easily exaggerated effect of their intervention. In further lecture, we will discuss the nice sugar trial also. The time frame for the primary outcome in hospital unit introduce the possibility of discussion of the result during the PPA. If patient need home but still time more for the significant outcome in this. 30-day mortality is frequently used to favor assessment of outcome, but this requires more trial resource to follow up the picture and patient. Thank you guys. Like and subscribe to my channel.